Okay, this video is called Why Big Surgery Kills Old People. Okay, and I sort of put this all together, and it basically totally fits my theory, the Peter Rogers, MD theory of supply and demand with regard to the brain. To become demented is like being dead because you really can't do anything more. Yeah, theoretically your body's alive, but you're like demented. And I've given a couple lectures recently on the effect of general anesthetics on the brain, of cardiac surgery on the brain. You know, valve surgery is much more brain damage likely than is just open heart coronary artery bypass graft to bypass coronary artery disease for atherosclerosis. In addition, general surgery of the abdomen is not as bad, but people can still have problems. So the question becomes always how much of it's due to the surgery, how much of it is due to the general anesthetic. And we're going to talk about all that in this lecture here. Old people at baseline, they're fragile. When people are old, they've already got diminished mitochondrial function. That's why they're so weak. Okay, that's the mitochondrial theory of aging. They're usually on multiple mitochondrial inhibitor meds. They usually eat a diet with multiple mitochondrial inhibitors in it. They usually don't filter the water. So the tap water's got aluminum, mitochondria inhibitor. Tap water's got fluoride, mitochondria inhibitor. They're very often on medicines that are mitochondria inhibitors like statins, like metformin, like antidepressants, selective serotonin reuptake inhibitors, beta blockers. Okay. They're often eating non-organic food with glyphosate mitochondria inhibitor, atrazine mitochondrial inhibitor in there. Okay, they got atrophic brains, typically weak mitochondrial function. Their immune systems are weak. All right, so at baseline, they're fragile. Then the next thing is surgery is psychologically stressful. The hormones of stress elevation are catecholamines and cortisol. Okay, caffeine does the same thing. But anyways, catecholamines like adrenaline, noradrenaline, same thing as epinephrine, norepinephrine. Those cause excitotoxicity, meaning hyperstimulation of the brain cells, increasing the metabolic rate of the brain cells, okay? So now you got an increased metabolic rate of your neurons, okay? You also get a little bit of hypoxia because it's a vasoconstrictor to the cerebral cortex. You sort of function in the mammal brain, if you will. Remember the brain's like three-part thing on the brain. You've got your brain stem, and that's like your reptile brain, primitive. Okay, then you got right above that your limbic brain and the midline sagittal. It's the cingulate gyrus connecting into the medial temporal lobe. That's sort of your mammal brain, like a dog, okay? And that's what you go into when you're psychologically stressed. And then you have your cerebral cortex above, which requires more blood flow and sophisticated, calm thinking and contemplation. Okay, but you shift into a mammal brain in fight or flight stress, which you're put into by the psychological stress of surgery. The fear of the surgery, then the pain afterwards raises the same hormones, the sleep deprivation. Hospitals are a terrible place to sleep. There's often a lot of bright lights, and they're constantly hassling you, poking you, checking your blood pressure, annoying you for whatever the reason. So it's hard to sleep well in a hospital, but your body needs to sleep to heal. Okay, and then the physical pain is psychologically stressful. That induces a SANS, sympathetic autonomic nervous system phase in the body. Okay, then there's very often perioperative hypotension. There's either hypotensive intraoperative when they put you on the cardiac balloon pump, or perioperative hypotension post-op. Let's say you go for a CABG, coronary artery bypass graft, because they don't want you to ooze blood, to bleed at the anastomosis, to bleed into your mediastinum. Okay, so perioperative hypotension drops blood flow to the brain as well as all that stress. So now you've got an elevated metabolic rate of your neuron with a drop in cerebral blood flow. That's also called hypoxia. It's focal neuronal hypoglycemia, lack of glucose delivered when you have lack of blood flow. Okay, so you're widening the gap between, normally they should be matched. That's what supply and demand is all about. The metabolic rate of the neuron should be matched by the oxygen and glucose delivery. But if you elevate the metabolic rate of that neuron and you simultaneously drop the oxygen and glucose delivery, that's not good. If this gap gets too wide, the neuron's going to die. It's going to go into apoptosis, programmed cell death. You won't be able to meet the energy demands of the flippase and floppase enzyme on the plasma membrane that keep phosphatidylserine flipped into the inner leaflet of the plasma membrane. When it flips to the outer leaflet, complement binds it, microglia, the immune cells, macrophages of the brain, then will phagocytize the neuron because they don't want it to burst. They don't want it to lyse, release its internal contents, which will then cause a localized inflammatory reaction and damage adjacent brain cells, collateral damage. So the brain just eats neurons that can't meet their metabolic demands. So you don't want your neurons to be unable to meet their metabolic demands. And then it gets worse than that. The general anesthetics are majorly toxic to mitochondria. They themselves can induce mitochondrial damage. I mean, you're very confident if you believe that this medicine can shut off the brain and then turn it back on again. You think the brain's just a light switch? No, you're messing with your mitochondria when you take general anesthesia. You really don't want to do that unless you have no choice. I mean, sometimes the benefits outweigh the risk and you need to do it. It's reasonable, okay? But you don't do it willy-nilly unless you have to do it. So You've got mitochondrial toxins at baseline, crappy mitochondria. Then you hit the mitochondria with these super powerful general anesthetics. The reason why you can undergo major surgery is because they've turned off your brain in a sense. Luckily, you're kind of turning off your immune system simultaneously, so you're not eating all your brain cells. But you're making a gamble, playing chicken with your brain cells, hoping they're all going to come on fast enough to not get eaten through the apoptosis mechanisms, okay? So that's why the cerebral surgery, it doesn't have to be cerebral surgery. It can be cardiac surgery. It can be any type of big surgery, abdomen, anywhere. That is, especially if it's long and prolonged, that stresses these old people. You've met all the criteria for dementia in an old person from the Peter Rogers, MD, supply and demand theory dementia. You've dropped the blood flow to the brain. That's like the Jack Delatorre vascular hypoperfusion hypothesis of dementia. You overstimulated your brain cells. That's like the cytotoxicity theories, the calcium theories of dementia. And you've simultaneously inhibited the mitochondria from energy production. That's the third tier of my supply and demand theory of dementia. This is what causes brain damage, and that's why so many old people, they lose it mentally after a big surgery with general anesthesia. That's it. That's the explanation right there. I ran this by my doctor buddies. They all agree I'm totally right. It totally fits all the known stuff. There it is. It's the simultaneous effect, synergistic, harmful effect of dropping blood flow, raising metabolic rate, and inhibiting your mitochondria. I mean, that's a brutal thing to do, and that's why a lot of these people, they go over the deep end. And so when I say surgery kills them, I had to make a quick title, but I meant that it mentally destroys them. A lot of them, they're never with it again after that. Don't get me wrong. Some of them become delirious in the post-op phase, cognitively impaired in the post-op phase, and then they recover significantly. But a lot of them don't come back to baseline and are significantly cognitively impaired to the point where, say hi to Uncle Joe, but, Uncle Joe ain't what he used to be.